Hello, my name is Dr. Simon Freilich, consultant in clinical neurophysiology. This video will provide you with an explanation of diabetic neuropathy, what it is, the different types and why patients develop them. You can also find out more about current treatments by clicking on the information card above. Diabetes causes raised sugar levels in the blood. This is called hyperglycemia. Hyperglycemia over prolonged periods of time is associated with blood vessel disease. When it affects the large blood vessels, it causes what we call the macrovascular complications of diabetes. This is where it can cause clogging of the large arteries to the heart, where it predisposes to heart attacks, causing clogging of the large arteries to the brain, where it can predispose to strokes, and causing clogging of the large arteries to the legs and arms, where it can cause peripheral vascular disease. When it affects the smaller blood vessels, it causes what we call the microvascular complications of diabetes, namely damage to the structures in the kidney causing nephropathy, damage to the structures in the eye causing retinopathy, and damage to the structures of the nerves causing neuropathy. This video will focus on diabetic neuropathy, i.e. the nerve damage caused by diabetes. Firstly, some statistics. Diabetes is really common, and in 2014 it affected 3.5 million patients in the UK, with this number steadily rising. Diabetic neuropathy will affect around 50 to 60% of diabetics. 25% of diabetics will have this as a painful neuropathy. Around 50% will have autonomic fibre involvement causing impaired bowel movements, for example, and for many men at least a third, erectile dysfunction. These complications are mainly time dependent, so the longer patients have diabetes, the more susceptible they become in developing these complications. They are also blood sugar level dependent, so poorly controlled diabetics are more likely to develop some of these conditions. Many patients do not recognise the symptoms of this and can present with further problems such as foot ulcers and gangrene. Thus, we really need to understand this condition, detect it early, prevent its progression and treat it effectively to prevent worse complications from occurring. When we think about diabetic neuropathy, we need to understand both the mechanisms of this condition and the different types of patterns of nerve damage that it can cause. This can help us determine the underlying mechanism of the neuropathy and target treatment accordingly. You can find a link to my overview of all of these different conditions hosted on my WordPress site by clicking the link in the information box below. So, let's try and understand the most important mechanism: metabolic microvascular hypoxia, or MMH for short. Nerves are living tissues and need oxygen to survive. They have tiny arteries called the vasa nervorum which pump blood laden with oxygen to them. Raised blood sugars bind to structures and proteins in the artery walls in a process called glycosylation and causes them to thicken. This is called diabetic microangiopathy. Because oxygen has to diffuse across the walls of the blood vessels to make its way into the nerve cell tissue beneath, any increase in blood vessel thickness will impair the transfer of oxygen. This causes hypoxia, a lack of oxygen to the tissue, which ultimately leads to nerve damage and death. In addition, excess sugars are absorbed into the cell walls of nerve fibres and are converted by the polyol pathway into sucrose and fructose. This then causes excess fluids to be drawn into the cells by a process called osmotic pressure. Swollen cells become enlarged and dysfunctional, which leads to further nerve tissue damage and impairment of transmitting nerve signals. Smaller nerves tend to be more susceptible to these processes, and so painful small fibre neuropathies are more common. We also often see a length-dependent process. This is where the more distant nerves, which are very thin as they taper off, become more affected as they're more susceptible. Hence, feet tend to be affected more often and before the hands. The type of damage diabetes causes usually affects the axons, i.e. the wire core of the nerve. It can also affect the myelin sheath as well, and this is particularly the case in poorly controlled diabetes. Diabetes can also cause activation of the immune system to inflict damage on the nerves by mechanisms we don't fully understand. These can cause inflammatory conditions such as CIDP, painful diabetic neuropathy with extreme weight loss, and contribute to the development of diabetic plexopathy and cranial nerve palsies. Nerves can also become more susceptible to compression neuropathies, such as carpal tunnel syndrome, cubital tunnel syndrome, common peroneal nerve compression across the fibular neck, and myalgia paresthetica. Mechanisms for this include linkage to obesity, increased nerve fragility, and fibrous deposition causing reduced mobility of the nerves across the joints. Nerves can also become damaged following complications of diabetes, which might be short-term complications such as hypoglycemic events or diabetic ketoacidosis. This is thought to arise either from a relatively transient metabolic dysfunction or from small clots blocking up the vasa nivorum. Additionally, they can also be caused by more long-term complications such as diabetic kidney failure. A very rare complication can also transiently arise following commencement of insulin, and this is called insulin neuritis, but fortunately tends to self-resolve after a few months. This slide summarises the different patterns of nerve involvement and the mechanisms we believe cause them. You can also download this by clicking the link in the information box below. You might also wish to review my overview of the different types of neuropathies for further information as to how nerves can become damaged.